Good afternoon, everybody. So we welcome you all into this next session of Masterclass on corneal surgeries, a power capsule. But before we embark on our a session, which will comprise of all corneal veterans from various parts of the country, Dr. Rishi Mohan will take the lead on presenting on pearls to perfect a PK. Dr. Titiyal will be speaking to us on DSAEK triple procedures and how we would get it right. The PDEK Masterclass, Dr.Soosan is unable to join us, and Sumati will be joining us shortly. Mastering manual DALK will be dealt with by Dr. Rishi Swarup, and I will be taking on all the bubble nuances in Big Bubble DALK. DMEK will be demystified by Dr. Samar Basak, and DMEK problems will be conquered by Rajesh Fogla soon after. It's unfortunate that all of them are not going to be on the dais together because all the co-speakers in this session are having simultaneous talks in at least more than 2 sessions right now. So they're all delivering their talks and will be joining us in sequence. And before we embark on our session, I have the privilege of welcoming Professor Lim Lee, who's joining us here from Singapore National Eye Center. She's the head of the cornea department of SNEC, a wonderful person, and very knowledgeable in the field of cornea and very experienced in cornea and ocular surface and refractive surgeries. I welcome you here, Dr. Lim Lee, and happy to have you with us today. She will be delivering the keynote address on management of ocular surface in cataract and refractive surgery, the APA CRS Principles of Preferred Practice. Over to you, Dr. Lim Lee.
Thank you, Professor Vanathi. I'd like to thank the organizing committee for the kind invitation to speak in this symposium. These are my financial disclosures. Recently, the APA CRS published a book on the principles of preferred practice in the management of ocular surface and cataract and refractive surgery. You can download this book for free at the APA CRS website. And so what is the aim of this book is to provide guidelines according to the levels of evidence and grades of recommendation for the management of dry eye after surgery. So this book was developed by a work group that was commissioned by the APA CRS department. And this is the work group. The editors are myself, Professor Tong from Singapore, Professor Yong from Korea, and the expert panel of reviewers are from the EXCO committee at the APA CRS. And this book is supported by the educational grant from Santan. All right, so what are the levels of evidence? Whenever we look at the literature, we should look at the levels of evidence, level 1 to 4. 1 is evidence, 1A, evidence obtained from meta-analysis or randomized control trials. 1B is obtained from at least 1 randomized control trial. Level 2 is evidence obtained from 1 well-designed control study. 3 is evidence from comparative studies, case studies, and 4 is from expert committee reports. And grades of recommendation is according to the evidence levels. Grade A is from evidence level 1. Grade B is evidence level 2 and 3. Grade C is evidence levels 4. And good practice points are the best practice in the clinical management. So why do we manage ocular surface? Of course, we know that dry eye and ocular surface disease is so common, not just in the elderly, but also in our refractive patients. And it affects the preoperative biometry, which is very important. You want to consider premium IOL, and also topography for our LASIK screening cases. It also affects the postoperative outcome, the visual refractive results, and the tear and the ocular surface control. And how does the surgery affect the tear film? First of all, it causes inflammation. It can affect the tear stability, the MGD, and it can affect the mucin production due to goblet cell injury, and it can also cause neurological injury by especially refractive surgery. And the preoperative assessment, very important to take ocular history. Symptoms of dry eye, previous eyelid surgery, previous contact lens intolerance. Systemic history is important. Autoimmune disease it is known to cause a significant, be a risk factor for significant post-op dry eye. This is a grade B recommendation. And if your patients are depressed and on antidepressants, that can also, the medication can also predispose to dry eye. And diabetes, very common in Singapore. 10% of our Singaporeans are diabetics. And this is a caution for refractive surgery. And it may have keratopathy and corneal neuropathy, similar to dry eye. And it may take a longer time to heal, epithelial healing. So this is a grade B recommendation. How about the meibomian gland disease prior to cataract surgery? Very important to remember that the extent of post-cataract surgery, tear lipid thinning and meibomian dysfunction is related to the pre-op severity of MGD. So it's important that you need to optimize your patient before operation, and this is a grade B recommendation. So examine, the rest of the examination will be the tear breakup time, tear meniscal height, fluorescein staining, Schirmer's test, and then you can also do confocal microscopy to look at the corneal nerves. Remember to lift up the upper lid, very simple test to check for conjunctival staining. And biometry, in cases with raised tear osmolarity, the keratometry should be repeated when tear status is returned to normal. This is a grade B recommendation. Very important to note, if your biometry is not consistent, you treat the dry eye first, ask the patient to come back again, repeat the biometry. And so it's important to note, delay your surgery if your patient has significant pre-op dry eye and ocular surface disease. Treat it first before proceeding to surgery. And intraoperative factors, remember to minimize conjunctival manipulation, don't manipulate too much, minimize operative time. And for refractive surgery, it has been shown that SMILE is better than LASIK in terms of dry eye symptoms at 6 months. This is a level 1A evidence here. And for LASIK, the corneal hinge position has a minimal effect. There's no difference between a microkeratome and femtosecond laser procedure. Level 1 evidence. And for cataract surgery, larger incisions take longer time for corneal sensitivity to recover. So this is a level 1 evidence. And how about femtosecond cataract surgery? Femtosecond cataract surgery takes longer, so it has been shown to have a greater OSDI at 1 week, level 2 evidence. So how do we treat dry eyes post-cataracts and refractive surgery? So of course, the first line treatment, artificial tears. And preservative-free artificial tears recommended for post-LASIK because you need to apply so frequently, preservative-free is recommended. How about for meibomian gland disease? Lid hygiene, warm compress, nutritional supplements, topical azithromycin, and oral doxycycline have been found to be effective for post-LASIK patients. This is a grade C recommendation. And for the oral antibiotics, tetracyclines and macrolides are effective in the treatment of MGD and blepharitis, cases that do not respond to lid hygiene practices. Azithromycin is able to normalize the lipid profile and relieve meibomian gland orifice plugging. This is a grade B recommendation. And for punctal plugs, in post-LASIK aqueous deficiency, dry eye punctal plug treatment improved tear film stability, symptoms, and VA, a grade B recommendation. And topical autologous serum reduces the corneal epithelial erosions and improves post-LASIK tear film stability more effectively than artificial tears, a grade A recommendation. And many publications regarding topical cyclosporine, most of them are grade A and B recommendation, and they show that topical cyclosporine A improved dry eye symptoms, the objective markers and the subjective symptoms over and above that of artificial tears. So it would be beneficial to treat your patients with topical cyclosporine if they have dry eye post-op. And topical steroids, okay, this is, everybody uses topical steroid after cataract or refractive surgery. This should be tapered after 1 month because long-term steroid use is not advisable. We all know the side effects. But for persistent dry eye symptoms, it is beneficial to give another short-term course, like 2 to 4 weeks. It's effective to relieve the symptoms. This is a grade A recommendation. And for non-steroidal anti-inflammatory, that's a word of caution. This may cause corneal melting, especially in patients with severe ocular surface disease. level 4 evidence. For eyelid warming therapy, this has been shown to be effective in dry eye symptoms after LASIK, a grade B recommendation. Thermal pulsation therapy is effective in relieving obstructive meibomian gland disease and restoring meibomian gland function. And a single treatment may last for up to 1 year. This is a grade A, level 1 evidence. But first of all, you should investigate first and do a meibography, because if it shows that the patient has extensive meibomian gland dropout, you may not want to subject the patient to this expensive treatment, because there will not be much benefit if there's extensive meibomian gland dropout. How about lipid-containing emulsion eye drops? It is very effective for meibomian gland disease, a grade A recommendation. Mucin secretagogues, this has recently been released by Santen, and a grade A to B recommendation. It shows that mucin secretagogues can improve the subjective symptoms and the objective markers of dry eye over and above that of the artificial tears. So in conclusion, dry eye disease after cataract and refractive surgery is common, and it may be due to a combination of direct damage to the surgical factors, such as corneal incisions, ocular surface manipulations, indirect damage from the ensuing inflammation. And the symptoms are worse in the immediate post-op period, and they tend to recover over time, usually after a few months. A small percentage of these patients continue to have persistent dry eyes, and these tend to have preoperative risk factors. So it is important to manage patients with the appropriate treatment for their dry eye disease. And it's also important to identify and treat susceptible patients prior to surgery to achieve an optimal outcome. Thank you for your attention.
Thank you, Dr. Limley. So now we will immediately embark on our corneal surgery masterclass. A short change a small change in the orders with Professor Jeewan Singh Titiyal, Head of Cornea Services Cataract Refractive of RP Center, will take the lead on telling us how to do DSAEK triple the right way.
Okay, thank you. Thank you, Vanathi, for including me in your course. In fact, any corneal field is, exciting for all of us. And because I have another course running, so I had to rush. Thank you for accommodating me early enough. We all know endothelial keratoplasty is the surgery of choice nowadays for all endothelial dysfunctions we have. And sometimes, because the age group is such, you have cataract also in these patients. So we like to do a combined surgery, or sometimes you can do a sequential surgery, a stage procedure. This will all depends on a patient's profile, the type of disease, the type of cataract, and the corneal problems patient is facing. And the surgeon has to make appropriate decision by good examination of patient, counseling of patient, then looking on what are your expertise in the field of surgery and make your decision accordingly. Looking at the Fuchs, which is a commonest disorder associated with cataract, where you can have chance of doing a combined surgery, there are certain guidelines where we should follow how to pick up these patients. So any patient who has corneal thickness much more than a normal cases, like more than 650, 700 in Indian scenario, or specular count which is less than 1,000 or 800 with very disrupted endothelial morphology, those patients who have symptoms of morning blur going for longer period and glare and halos should be taken up for a combined procedure if you have a setup. But things which are not appropriate for doing a combined surgery would be those cases where you have a good corneal features, corneal thickness less than 600 or 650, reasonably good endothelial count, and patient having a significant cataract. You can always plan for a sequential surgery for those patients. So there are three important things: one, the patient's symptoms, the corneal thickness, and the endothelial cell count in these patients. The advantage of combined surgery is always there because it saves the time, the cost of the patient, the frequency of follow-up also decreases, and the risk is quite minimized in these cases because we are doing a two surgery together. This is one of the landmark study from Mark Terry group where they looked into a combined procedure in a Fuchs patient with cataract, and they said that safety-wise, it is a safe surgery. There's not much increase in the complications as compared to a simple DSAEK procedure in triple procedure. As such, efficacy-wise, you can see all these patients had a very good results in terms of acquiring visual acuity, and the post-op refraction also was not grossly deviated as you would perceive in a triple procedure doing in a penetrating grafts. So this is advantageous, efficacious as such doing a triple procedure. So it has a rapid visual recovery and allows a selection of appropriate intraocular power of lenses, because we are not doing a full thickness graft where we induce so much of corneal toricity and the corneal curvature changes so much, the IOL power gets haywire. But sometimes looking to a disadvantage of combined procedure, definitely there's an increased risk of posterior capsular dehiscence or rupture, because your visibility may be a little hazy in such cases, so you have to be a little careful in such scenarios. And there are a few important tips which should be looked into for doing triple procedure. Normally we pick up a monofocal hydrophobic lenses. Hydrophilic lenses should be avoided because sometimes air injection during the procedure can cause anterior surface opacity of these IOLs, hydrophilic IOLs. Toric and multifocal accommodative we normally avoid in such cases. We always talk about hyperopic shift in a triple procedure with DSAEK because we put a thick lenticule in these cases. Conventional DSAEK triple will require around 1.25 myopia being corrected. But in my own practice, I do a ultra thin DSAEK where I just make 0.3 to 0.5 myopia in these cases. As we have seen, all these lenticule which you put in these patients subsequently next 3, 6 months, 1 year, the lenticule becomes thinner and thinner. Towards the end of 1 year, it is hardly 50 or 60 micron thickness. That doesn't induce too much hyperopia as such. These are few steps of surgery which I'll come subsequently. The capsular excess has to be manageable. It should not be too large because the optic might come out during your procedure. It should be just 5 millimeters so that it covers the entire optic of the IOL. If possible, slightly bigger optic IOL will be better. Don't use 5.5 or 5 millimeter optic in your cases. And make sure you remove the entire viscoelastic from the anterior chamber, both from the anterior and posterior surface of the IOL, and pilocarpinate the pupil before you insert the IOLs. These are very, very important. As I said, the symptoms are very important. Cellular morphology, like this patient, and has a corneal thickness. 3 important things which are important here. This is one of the cases of Fuchs patient with early cataract. Even patient doesn't have a cataract. Sometimes you may have to do a triple procedure in these patients because of age group. Subsequently, they'll develop cataract and you require a second intervention. It's better to handle these patients as a primary surgery. As I said, the IOL power calculation is not a challenge for these patients, and you have a very nice post-op refractive error in these group of patients. You can see a nice capsular excess. Phaco is simpler. If you have a difficulty, you can have an anterior chamber phaco also. Important thing is to safeguard the posterior capsule in these patients. After you aspirate the thing, you can implant the IOL, and the important thing is you can do a descemeter rexis in a viscoelastic cover, which gives a very nicely formed chamber, and the crumpling of descemeters is also good visibility because pupil is dilated at this stage. You can take out very nicely the disease endothelium by doing rexis in these cases. Subsequently, take out with irrigation cannula and do a complete visco aspiration, pilocarpinate the pupil. Then normally I use Buson's glide for all my patients, and it can be pulled in, and you can see nicely it can be pulled in, and make sure the graft is just floating. Don't take out without unfolding the graft with your forceps. Don't leave the forceps whole. Subsequently, you can inject air bubble and maintain the graft position very, very nicely for an important time. But sometimes you have a patient like this which has a hazy cornea, a lot of epithelial edema. This is again a Fuchs patient. The epithelial debridement gives you a more clarity of anterior chamber view, and you can do a nice surgery, and this should be removed. If you have IOCT, that also gives you a thickness of a cornea and thickness of a donor tissue also. It's important to have a good visibility. You may stain the anterior capsule sometimes, and that also gives a good visibility. Subsequent surgery is simpler. And you can have viscoelastic over the cornea also, and you can subsequently correct this. So this is another case scenario where we have used similar tissue from the opposite side, inserted inside, and you can complete this thing. This is immediate post-op result. This is after 3 months. This is after 1 year, and they have a very good results in these cases. See, this graft is just 67 micron after 6 months. So this is what is advantage of ultra-thin tissues. or average thickness has been 50 to 80 microns at 6 months, and results are very good in such cases. IOCT assisted surgeries are a very good concept because that gives you a good appearance of a donor tissue as well as the apposition which happens on the table. You can nicely see this is towards the end of intracameral pressure and external massage. Internal graft is attached, and after removing the bubble, you can see still the graft is attached. Very small bubble is left. So this is, if you have a good visibility, you can do a very nice surgery in these patients. So I would say DSAEK triple is desirable in all those cases where you're doing DSAEK in adult patients, and it is safe, effective procedure and feasible because IOL power calculation doesn't go haywire in these cases. And if precaution is complete removal of OVD, nice decimeter access, and ultra thin preparation of that lenticule gives a very good result in these cases. Thank you for your kind listening.
Thank you very much, sir. And before we throw the hall open for questions, if you are advising a DSAEK triple for a beginner who's starting endothelial keratoplasty, sir, what would be your word of caution? Or would you say, would you advise them to do sequential procedures separately, or would you advise them to go and what's your take on that, sir?
No, if you are a beginner, it's better to do a sequential surgery because that gives a much more comfort. Sometimes your phaco may not go as you think, it gives you a lot of difficult phaco times. Some of the older patients, especially male patient, can have a lot of floppy iris, and the pupil can get distorted, a lot of pigment release. Those cases can have a difficult graft attachment. So it's better to do a phaco first, wait for at least 6 to 8 weeks. Then in a cold condition, a cool eye, you can do a DSAEK surgery in those cases. Because for a beginner, the apprehension will be double. First, completing the DSAEK surgery, phaco surgery, then doing a DSAEK surgery, and surgery is also prolonged. But if things are quite comfortable, triple procedure is not a big problem for our DSAEK surgeons.
Thank you very much, sir. Are there any questions for Dr. Titiyal, because he will be shortly leaving us for his next session? Thank you very much, sir. I will now welcome Dr.Rishi Mohan, Director of MMI-Tech, a wonderful person, excellent surgeon, and he's been running consecutive courses on keratoplasty in the ESCRS sessions almost, I think, for over a decade now. And he's going to tell us how to perfect doing penetrating keratoplasties and how you can enhance your results in PK. Thank you, and over to you, sir.
Thank you, Dr. Vanathi. Good afternoon, everyone. Thank you for this opportunity to be a part of your course, Vanathi. It's always a pleasure. What I'm going to do is essentially introduce the techniques of keratoplasty, really. And for all of us who are in this hall and all of us who are trained as corneal surgeons, what do we train in? We essentially train in, what's happened to this mouse? This mouse is gone. Okay, better now. So earlier, when keratoplasty was originating in 1905, the anterior lamellar grafts were the norm till the importance of the endothelium was widely accepted. And it's only later, almost 70, 80 years later, that the understanding of replacing only the diseased tissue came back to the fore, and history essentially turned full circle to allow for anterior and posterior lamellar surgeries to be done. However, penetrating technique still remained the gold standard in transplantation procedures, and essentially because this was the only technique that was considered effective and easy, all of us as corneal surgeons learned the PKP techniques during training. It's a relatively straightforward procedure. It has universal applicability for corneal transplantation, right from anterior stromal disease to the posterior or the endothelial dysfunction, essentially, which means that one technique fits all. And in any case, when you look at late stage presentations, whether it's Fuchs dystrophy or whether it's CHED or whether it's any dystrophy, essentially the whole cornea eventually gets involved. And if patients present late, then only a full thickness corneal replacement is the solution. These are some of the indications which are just available in standard texts. And as you can see, almost any corneal pathology is amenable to a full thickness transplant. Of late, we have had so many advances in our experiences and in their operating microscopes and surgical instruments, the sutures, the availability of better corneas, and now, of course, the femtolasers to enable a better cut profile and flange. These have improved the outcomes a lot. So coming to the procedure itself, we should talk about the preoperative preparation. The use of preoperative antibiotics and steroids. This would again go across all forms of keratoplasty. Attempts to decrease the vascularization, IOP lowering agents, the peri and intraoperative preparation with the pupil, and the intravenous mannitol or intravenous diamox, steroid and antibiotic injections at the end, and the kind of anesthesia. I personally prefer for my full thickness keratoplasties a general anesthetic, as I think many corneal surgeons would. It just gives you less stress while you're doing the surgery. But local anesthesia combined with lignocaine and bupivacaine also works well, provided you can achieve good akinesia. So this is just small little clips just to show how important it is to center these grafts. That's a barren punch that you have on the top to prepare the donor, which is what I would in conventional keratoplasties do before I do the recipient. And then at the bottom here is the use of the Baron Hesburgh trephine, which is again my favorite. It's a vacuum-based trephine, and after marking the cornea, one can go ahead and trephine. I often don't do the full thickness of the trephination because I don't like the gush of fluid, and I will leave the last bit to be done. As you all know, this trephine can also be used for lamellar surgeries. We know that one full rotation, which means 4 quadrants of full rotation of this trephine, will give you 250 microns of cut. So that's how the donor is prepared, and then it's covered with the viscoelastic and a little bit of the medium. So when we've done the astigmatism and we've done the trephination, we should look at the suturing and evaluate the kind of trephination that we've done. So one of the biggest reasons why we don't have good quality vision sometimes in our grafts, and that relates to lamellar grafts as well, is high post-operative astigmatism. And one of the major factors in this is the ovality in the cutting. And so ensuring that you have a round donor cut and a round recipient cut is extremely important. And we know that ovality produces significant amount of astigmatism. Of about even a 0.3 millimeter of ovality will produce more than 3 diopters of astigmatism on this account alone. The bevel is another issue wherein we have to ensure that we get a vertical cut on both the donor as well as the recipient. So the objectives of suturing are to obtain a perfectly aligned and watertight closure rapidly with very little override or posterior gape, and to minimize the tissue compression and unequal tension, and for that one needs to prefer shorter and deeper bites. We must optimize the fit by increasing the sphericity, ensure the best apposition when the graft is placed in the recipient bed. Always try and grasp tissue radially with the anterior lip in your grip and not the full thickness, and the suture should pass directly beneath the grasp point to reduce torque. Using slip knots and keeping them fairly tight in the cardinal sutures is extremely important, and one must maintain the depth of the anterior chamber as one works. So this is some of the principles that you'll see being highlighted here. You can see here that the tissue is resting on a bed of helon, essentially, which is sitting in the anterior chamber. There's a Fleringer ring, if you notice, and that ensures that you have, in this patient who's had a vitrectomy, ensure that you don't have globe collapse and you will not produce a malapposition inadvertently, because even slight malappositions produce significant amount of astigmatism post-op. The use of the slip knot is being demonstrated here, wherein you can use a single throw and then come around and do your pulling in a north-south fashion. And I'll show you here how you titrate the slip knot. And as you can see, you'll notice, is there a pointer here? You'll notice a little bit of whitening just about there. See that whitening come up? That whitening is what tells you that you've got adequate tension in your knot. And that whitening tells you that there's good quality apposition. If you over tighten it, you'll have too much whitening and you can loosen it. And then you lock in the knot by doing some east-west throws, and you're done with the slip knot. And you can do the same thing all around and pretty much continue with the cardinal sutures. Oops, there's another little tip that I wanted to actually show you. I'll have to go back to the previous one. Do I have time, Vanathi, or am I run out of time? I think I am running out of time. All right, so I'll just move on. Essentially, what I wanted to show was that one of the ways to find out the best position for the 6 o'clock point on the donor is to use the thread, and don't cut it when you've done the 12 o'clock suture, but use the thread to go and find the best point that you have at the 6 o'clock position, and it gives you the best possible apposition. Here, of course, one sees the final closure in this patient. We've done 8 cardinals, and we're going to put in a 16 bite continuous with it. And as you can see, the bites are all radial and are deep as far as possible. And at the end of the surgery, we have a very nice look to it. When we are finally closing these grafts, it's important to do 2 things. 1, deepen the chamber. Don't finally do the closure of the final knot without deepening the chamber. 2, release any bridal sutures, release this, the tension from the speculum, because that will help get you a much better closure without the chance of wound leak or excessive tightening. We also use a ring like this or a device like that to try and see if we can get some sort of circularity of the Myers. Any additional procedures, again, and that's where keratoplasty of a full thickness has value, is that when you have a very opaque cornea and you have to do the whole thing, you have to do open sky techniques, and this is an open sky rhexis being performed. We are also, the advantage of knowing the penetrating keratoplasty techniques is to do things like regrafts, and then you have very bad patients like these, wherein I'm not even refining, I'm just using the old regraft area to try and see if I can tease open the same little area and put a new graft in it. And you can see on the top that I'm completing the rhexis in an open sky method. And after that, I can just deliver the nucleus with the simple hydrodissection, do the IA, and let's see if I can fast forward this. This is my last slide, actually, Vanathi. So that's the nucleus being delivered, and that's just the IA being done. Here on the lower side, you can see a vitrectomy being completed, and after that, the positioning of the graft, pupilloplasty. These are again only possible through full thickness techniques. It's very difficult to do these maneuvers if you've got a very small or a narrow opening. And DALK pretty much follows the principles of a full thickness keratoplasty, but all the endothelial keratoplasty techniques actually follow more cataract principles than corneal surgery principles. And so there's quite a bit of difference between the way the traditional corneal surgeon works and the DSAEK surgeon. Thanks so much, Dr. Vanathi. Thank you so much for everyone for giving me a patient hearing. Thank you.
Thank you very much, Dr. Rishi. And are there any questions for Dr. Rishi, any of the budding corneal surgeons here, or if you want anything which Dr. Rishi will be happy to clarify you as Dr. Sumati would set up her slides. Yes, please. Please come over to the mic.
Can we have the lights? No, it isn't, unless the patient is you're doing a fresh pseudophakia. If he's a round pupil pseudophakic from earlier who's stable, you can do a PK without doing a PI. If there is a vitreous possibility, do a PI.
Yeah. Dr. Rishi, tell us about flaring as ring, advantages and disadvantages, and how often you use it.
Good question. All my aphakics, I'll use it. I'll use it in all my pediatric cases. I'll use it in patients where I expect that I'll be spending a lot of time doing reconstructive work. People who've had traumas, I'll use those. So those are pretty much my indications for doing it. I don't see any real disadvantage other than the fact that it takes a little time. It just adds 5 or 7 minutes to your surgical procedure because you have to first put it in, then you have to take it out. And then you need a little bit of experience because it does interfere with some movements, especially when you're passing your sutures. Sizing is very important. If you have a fairly large size graft, ensure that you've got a 16 millimeter Fleringer ring. Otherwise, you'll have problems as you're passing your sutures. That's about the only tips really, but it's a fantastic tool. Any other questions?
Thank you very much, Dr. Rishi. Thank you for joining us when
Thank you
you
so
are
much.
chairing another session out there. Over to now Dr. Sumati, Senior Cornea Consultant in Agarwal's Eye Institute, Chennai. And she's going to talk to us on all the details of PDEK surgery.
Thank you, Vanathi Madam, for giving me this opportunity. PDEK or predesmate endothelial keratoplasty is a surgical technique wherein you transplant posterior 3 layers of the cornea, that is the predesmates, desmates and the endothelium. All these surgeries are done for the corneal decompensation. So before going into the actual surgical techniques, well, let us know when we inject air into the posterior stroma of the cornea, we'll come across 3 types of bubble, that is type 1 and type 2 and a type 3 bubble. Type 1, the air separates the predesmates membrane from the posterior stroma, and the type 2, here the air separates the predesmates membrane from the desmates membrane, and type 3 is a mixture of the above two. So I'll discuss about how the surgical techniques and also the difficulties which we faced and how we come across the problems. This is my financial disclosure. Yeah. We inject air into the posterior stroma using a 30 gauge needle. When we inject the air, you can see the air is lifting the predesmates layer. So this is separating the posterior stroma and the predesmates layer. Once that is done, then you harvest the bubble by entering the bubble edge by the side port knife, and then cut the edges with your 1/2 scissor. This is the type 2 bubble. You can see it is forming from the periphery and involving the limbus to limbus. And this is the type 2 bubble, type 3 bubble, where you get a mixture of all the 3. So next step comes your desmetorexis. So as all we know that we most commonly all the surgeons do perform the desmetorexis with a viscoelastic. You can see here with the viscoelastic, the chamber is not very deep, and whatever maneuver you are doing, it is doing in a shallow AC. So even if you are in a phakic eye or any other IOL when you are doing, you can actually damage the IOL or even the PC when you are doing in a shallow anterior chamber. So you have to come out, inject viscoelastic multiple times, and then go again and do a desmetorexis. And before injecting the graft, you should actually wash the viscoelastic thoroughly before you inject the graft, because it will interfere in the graft attachment. So we thought you should have a deep anterior chamber. Why not do the desmetorexis in a air? So yes, we did achieve a continuous flow of air. We did achieve a deep anterior chamber. So what we did is we initially connected a 27 gauge cannula to an air pump, and then we did the desmetorexis. But still in this case your left hand is not free, but still the chamber is collapsing. So what we thought is we need a continuous flow of air to make the chamber deep enough, and your left hand should be free. So then we connected the air pump to a IC maintainer, and then you can see, you can see the chamber is very well formed, and your maneuvering in the anterior chamber is much more easier. Chamber is very much deep, so whatever you can do, you can easily do it with ease. This is an ICE syndrome where you can see a corneal decompensation with cataract, and there is peripheral anterior synechiae all around. So we planned as a triple procedure, first cataract followed by the endothelial keratoplasty. So as usual, we are doing a cataract surgery and IA, and then followed by a lens implantation. In this case, I cannot go ahead and implant an AC maintainer over here because there is a pass all around. What I did was I connected a 26 gauge needle to an air pump, and with this continuous flow of air, I am releasing the peripheral anterior synechiae all over. See, with this, my chamber is maintained, and the continuous flow of air is not allowing any bleed from the iris, which can happen when you are releasing the pass. So once my chamber is deep and peripheral anterior synechiae is released, I am connecting my trocar anterior chamber and connecting to an air pump. Then I am going ahead with the desmetorexis. See, there is no bleeding, there is not much of inflammation you will get in the post-operative period. So next comes the insertion of the graft. The main key point is before injecting your graft, you have to take off the air from the anterior chamber, and then you inject the graft. I am loading the graft into an IOL cartridge. So with an endo eliminator in place, you can see the orientation of the graft is very well identified. The scroll is facing up. With this, I am going to inject the graft into the anterior chamber. Once the graft is there in the anterior chamber, we have to first suture the main wound, because without that, if you try manipulating, Without that, if you try manipulating, the graft can come out. So I'm injecting the graft into the anterior chamber, and then the main wound is sutured. So with the endoeliminator placed on the cornea, you can see the orientation of the graft is very well identified. In this case, the graft is upside down. So this you can actually not very well appreciate with a microscope light. The moment I'm keeping an endoeliminator on the cornea, I'm able to identify the correct orientation of the graft. Once the graft is unrolled, I'm going with an air-filled cannula and injecting the air, and then connecting the air pump. So now the centration of the graft, unrolling the edges is much more easier with the air pump on it. This is a post-op picture of the same patient. This is a 4-week post-op, patient is 6 and doing fine. I'll show another case wherein these are the advantages of air pump assisted PDEK. This is another case where there was a PCIOL in the anterior chamber which caused us a bullous keratopathy. The graft is harvested and we are storing in the MK medium, and we are going ahead and doing a standard glue diol technique. Flaps are created on either side. After sclerotomy opening and thorough anterior vitrectomy, the same PCIOL is being repositioned for glue diol technique. Once the haptics are exteriorized, we are going to tuck the haptics into the Charette tunnel. This is an important step which you should do before going ahead into injecting the graft. Here if you see, we have done a glue diol and we don't have a posterior capsule here, and in superiorly also there is a broad iridectomy which was there, iris is damaged because of previous surgery. So when I'm injecting the air is not staying in the anterior chamber. Staying of air is very important to determine the graft adherence in the postoperative period. So I'm going ahead and doing a pupilloplasty before injecting the graft. Once the pupilloplasty is done, you can repeat the air test. See, the air is nicely staying in the anterior chamber. After that, desmetorexis, and I'm loading the graft into the cartridge and injecting it. See, you cannot identify anything with a microscope light, and then the moment I'm placing, you can see the orientation of the graft. You can press on the corneal tissue to see the opening of the graft very well. That is like, you can actually see a very well unrolling of the graft. Once that is done, so I'm injecting the air underneath the graft, and the graft is very well attached, connecting the air pump, and you can see there is a peripheral fold of the graft which I'm unfolding with a continuous flow of the air in the anterior chamber. Once I'm done with that, I will do little anterior vitrectomy on under the scleral flap and gluing of the flaps. And this is a post-op picture of the same patient. And when compared to the other surgical endothelial keratoplasties, PDEK graft handling is much more easier when compared to the DSAEK or DMEK graft. And the most important point is harvesting a PDEK graft is donor age independent, because even we have the youngest donor cornea which we used is of 9 months old donor cornea. Thank you.
Thank you very much, Dr. Sumathi. So that was a very detailed account on PDEK surgery. Do we have any questions for Dr. Sumathi? Any clarifications which you would want to have with her? Any tips, Sumathi, which you would like to give on how do you achieve donor preparation in PDEK?
Ma'am, first selection of your donor cornea. As I said, the more the younger cornea you choose, the better will be your bubble formation. And once you start injecting into the posterior stroma, you have to notice the type of bubbles which are forming. Usually when you go into the posterior stroma, you will see multiple small bubbles which is forming in the center. With a controlled injection you have to do. When you see that multiple small bubbles which are forming in the center, you can actually reorient your needle, and you can enter into one of those bubbles and then slowly inject, so you get a type 1 bubble definitely.
How would you fix or position your donor button, and how do you place your donor button when you're injecting air into the donor cornea?
With the endothelial, on a Teflon block, you place your donor cornea with the endothelial side facing up.
Okay.
And that tip which I would tell everybody is that the 30 gauge needle which you are using to enter into the posterior stroma, the limbal part is the place where you identify and you start forwarding your needle from that limbus towards the posterior stroma. definitely yes, that's a landmark which I tell them.
Thank you very much, Smriti, for being with us. And we will now move on to the next talk on endothelial keratoplasties by Dr. Samar Basak. Needs no introduction. Over to you, Dr. Basak, on teaching us how to demystify DMEK.
Thank you, Dr. Vanathi, and this is after PDEK to DMEK. And not moving? No. If you see the US data, gradually the DMEK is increasing, and latest data in 2017 says that it is 30% of all EKs. Still people are doing 70% still doing DSAEK or DSAEK. In India, a lot of surgeons are now doing DMEK for last 3 to 4 years. And US, the technicians actually prepare tissue for DMEK surgeon, which is pre-stripped, and iBank charges 1,000 to 1,500 USD more for pre-stripped. But if you have, you can prepare the tissue yourself. These are the simple instrument, you can use it. Initially you have some problem, but later on you can easily. This is my regular technique. I use, this is just 9.5 millimeter partial definition, then trypan blue staining, then you remove the peripheral DM with the help of a McPherson, and that edge lift in certain areas to see whether it is cleared. And now second time trypan blue for better visibility of the edge. Then you just with one hand pull technique you can go. Normally nowadays it takes for me around 3.5 to 5 minutes to prepare this tissue. Then this is the stromal punch with 3 millimeter skin punch. Then you lift the lid, dry the area. This is very important, otherwise the A stamp will not be that good. Then cover the lid and then clip the cornea, and desired is normally 8 millimeter in our country. So use 8 millimeter, remove the redundant endothelium and then clear it, trypan blue staining for 2 to 3 minutes. And it has shifted into the one bowl and injector system. So we now understand, I started in 2009, got the best video award from American Academy, but I had several failures for every year. So every year I start and stopped. Later on this 2016, I know that the dim scroll pattern, S mark, and surgery is going and most smooth in most of the cases. This S mark is very important for us. Somebody put P, F, or whatever. So S stand for stromal side. So the recipient steps are both are similar, except that main incision in DMEK is like it is almost always now it is sutureless and always corneal or maybe posterior limbal. Case selection same. Inferior is mandatory for DMEK. Anterior chamber should be shallower. Graft transfer is difficult only by injector system. There are various techniques for DSAEK graft transfer. And if you see that unfolding is easy with BSS and AR with the DSAEK, but here it is most difficult. So mostly by no touch technique, and so you have those marks. Centration is easy, whereas DMEK it is difficult. AR injection, AR it is for 10-15 minutes, then you can replace with some AR with BSS. But here just we put the AR injection from the center, and it is crucial, and just AR fill for, just firm AR fill, not very hard, for 45 to 60 seconds, and flat supine position DSAEK is more. DMEK, that 1 hour is sufficient for patients' early mobility. So these are the routine, nothing, initially surgery time was 50 to 60, now it is almost in 20-25 minutes I used to finish the surgery. And I advise standby optical quality tissue for 10 to 15 cases. And recipient marking, these are all similar step. I am skipping this. Main incision and side ports, your side port internal incision should be outside the template mark, otherwise during injection that will create trouble. And main incision might be corneal, clear corneal, or it may be like you can give sclerocorneal and like our phaco incision 3 to 3.2 millimeter because it has got least astigmatism. Then you have the same kind of donor DM-Rex6 except that it is slightly larger than DSAEK, so that we try to put the whole lenticule in the bare area of the desmet. Then you have like other types of donor scoring. That inferior PI is the most important part for DMEK, and you can do externally or you can have from with a vitrector, but there is a bleeding normally and you have to be very careful and you have to inject air immediately to prevent blood oozing. So that is tamponade is very important, air tamponade. But in clear cases you could do actually PI in the outdoor and take the few hours to few days before surgery. So donor transfer is regular, like you can have the transparent one, you can just fill the, without touching the, you can just ship the donor into the easily. Then you can have directly, you can take it into the, if your scleral rim is good, that fluid is sufficient, you can directly take the whole thing into the injector system from the itself. So there will be less damage of endothelium. And then the make your own injector every day you can make. You need this, I use this very frequently. This is a saline tube. You take the rubber part, cut it, and this is the Technics Curtis, Technics multi-piece Curtis butterfly. You break the Curtis and this snugly fits and you fit it into 2 cc syringe. So every time this is a new injector for you. So there is no need of, there's other glass injector is heavily costly, it is 16,000 if it is breakable, that is the problem. So I use, this is very useful for me. An injector, this is a scleral tunnel, so you just inject it, tap. You don't require suture in most of the eyes, but first unroll it, and you see that with that same tip, you just see that this thing is curl is like this, so you know you are in a right time, and with fixation of with one hand with a narrow cannula, 2 cannula, 1 cannula, 1 fine instrument, maybe Sinski hook or iris repositor, you can do that, and with gradual with the play with side ports and main port and also BSS, intermittent injection and shallowing of the anterior chamber. These are the tricks actually. Basically a lot of surface tension, then capillary action, all these things are happening here. So you just unfold it completely, try to be in the center. Our corneal size is smaller, so you cannot take more than 8 millimeter graft. So when it is unfolded completely and then you actually put the whole thing in the, you see that with little tap from the center, it unfolded it, make it central, and then from one of the side port you check that which side port is actually free so that you can injection can go directly into the center just around the pupil and put air bubble. This is the complete air fill, not over tight. You check the tension, tension is around 30-35 and close down. This is with like injection. So after injection you just put a suture, that is very vital. Otherwise this during manipulation donor may come out through the main wound. So you just rotate it. So it is a little tight roll, but still you can, when you just decompress the main port and other port, the mechanism is like same. I use this technique for my most of the cases, this technique are very useful for me, and it takes this unfolding. Some days it takes only 30 seconds, some days it is within 2 to 3 minutes I finish this unfolding part, except in hazy eyes. When you see that ace in the center, you are happy. You are happy and your job is done. So you see that center S mark is so visible and it is perfectly centered. There are other videos, I am skipping this. So only thing that immediately after, I don't keep the patient on the table, just I close the wound, send the patient to the recovery room, keep the patient for 45 minutes to 1 hour, then examine under slit lamp. In sitting position, if the air bubble is above the inferior PI, just fine. I ask the patient to shift the bed and lying for few hours. If not, PI is covered by air, little burping of air from one of the side port using 30 gauge needle or McPherson forceps. Immediately I find some fluid level, and we usually keep the patient overnight. So the more you do, you learn DMEK quickly. You need patient's pool. Initially do few cases in a row, at least 2 to 3 in a week. Watch YouTube's video and talk with the masters. And if you see that my data, this was, I started in last April. I was very anxious when I start. My data from April to like October, it is 1 to like this. But I went to American Academy and I got clue from some of the masters and I talked to them. Then suddenly my number increased. And if you see that in January to December, I did 202 DMEK. And my DSAEK was 51. So I have a huge patient pool. I am fortunate. And you know that Fuchs dystrophy is common in Bengal. It is commoner than any other state. We need to find out, and it is 40% in my series, and it is a huge figure. Now I have crossed 325 last month. So the take-home message is case selection is important for initial cases. S mark or other marks on DM side, recipient DM scoring 0.5 millimeter more than the donor size, inferior PI is mandatory, immediate air tamponade after PI because the bleeding is a nasty thing, it can spoil your surgery. Maintain shallow AC throughout during donor manipulation, homemade injector system, no touch technique for donor unrolling, air bubble size like 80 to 95, just firm fill air, not over tamponade, and standby optical quality tissue for first 15-20 cases. Thank you very much for your patience hearing.
Thank you very much, sir, for a very comprehensive cover of making look DMEK very easy. Believe me, it is not that easy as you make it sound, at least during the learning phases. Do we have any questions for Dr. Basak before he leaves us?
Yeah, Dr. Basak, 2 questions. I mean, what is your success rate in procuring the flap for DMEK in the beginning and now? And the second question, what is your rebubbling rate, which is in more in DSAEK or in DMEK?
So 2 questions. One is the tear rate. Success rate is now 99.5%. Initial 100 cases we analyzed, we presented a paper yesterday, it was 97%. So initial hiccup, when you know that, and we could reuse those tissue for DSAEK. Recently I had, after 100 cases, I had one, I could not, multiple radial tear, so I converted into DSAEK because I am in 9.5 millimeter area, so I will take, so multiple radial tear. So I could not initiate to make a flap. This is number 1. And second point is rebubbling rate. In my series, in first 100 cases, it is partial detachment is a more problem with the DMEK. Total detachment happened in 1 case and partial detachment like 9 cases, and we give air in those 9 cases in 3 cases, 6 cases spontaneously resolved. Total rebubbling out of 300 is 5 only. I take the patient to OR. But there are many patients of partial detachment, peripheral partial detachment, even central partial detachment, watched over a period of time, by usually it resolved by automatically. So DSAEK rebubbling rate for my cases right now it is 0%.
Thank you very much, Dr. Basak. And now over to Dr. Rishi Swarup. Again, needs no introduction for Rishi. So do take us on in the next 10 minutes on how to master manual DALK.
Thank you, Dr. Vanathi. It's been a privilege to be part of your course every year. So this time I'm talking about manual DALK, one of my favorite corneal surgeries, and I think DMEK is now my next favorite surgery. There are various techniques of DALK, and that's because each technique has some limitations. Just like DMEK, DALK also has a learning curve, and it has its own set of complications. So that's why we have so many techniques. The big bubble technique is the one which is very popular, which was invented by Anwar, but even that is not foolproof, as I'm sure has been discussed or will be discussed later in the day. So in this, basically we inject a bubble of air in the deep stroma, and that is then expanded till about 8 millimeters, and that has a central translucency with a feathery border, and essentially we excise the stroma anterior to that and leave behind the predesmetic layer, which is the Duas layer. So when should we do manual DALK? If you don't get a big bubble, that's the obvious next choice. In advanced or extreme ectasia, such as this picture with advanced pellucid, the big bubble doesn't go to the peripheral cornea. So you have no choice, you have to do a manual DALK. If it's very advanced, there's no working space to kind of do a bubble. So again, in such cases, it becomes safer to do a manual DALK. High-risk grafts, where you just don't want to have a perforation at any cost, you may want to do a pre-desmetic DALK and leave behind a little stroma as well. Or if you have involvement with the posterior stroma, like in that OCT, you can see a thickening of the descemes membrane with a scar, probably because of an old hydrops. In such a case, doing a big bubble will cause a rupture, and you will have a problem. So you have to do again a pre-desmetic manual DALK, or a contradiction for a big bubble. So the conventional way of doing a manual DALK is to do a cut and peel, in which you use a scissor and keep dissecting layer after layer. But what happened in that case can happen to you. You can have a perforation, and that's because you're using a sharp instrument to do the dissection, and layer by layer sometimes you can't gauge the depth properly, and just 1 second it takes to just rupture the Duas layer of the descemes. If it happens in the periphery, you can manage it like this, but if it happens in the center, it can be devastating. So that is one of the limitations of the traditional cut and peel technique. The other technique described by Arkila was the air insufflation technique, in which you inject air into the stroma. It thickens the stroma and makes it opaque. So then when you're doing layer by layer dissection, you know how long you're in the stroma, because it's going to be opaque. And the moment the opacity goes away, you know you're close to the descemes membrane. So you can, sometimes this happens when you're attempting a big bubble, it becomes opaque like this, you get emphysema in the stroma, and that then in such cases you can do a similar kind of approach. Another technique which the Japanese ophthalmologists often were using was the hydrodelamination, in which you inject fluid into the stroma, and again the same effect, it thickens and opacifies it, and you can then remove either layer by layer or any of the techniques to kind of reach the predesmetic space. So even though you may not use this technique, you can use this principle when you want to kind of find a plane and you've kind of lost the plane during dissection. You can thicken the stroma and then kind of make a little pocket in the stroma to get a plane for dissection. So use the principles of multiple techniques to arrive at your own technique of manual DALK. So this is the case where I was doing a DALK and I lost the pocket. So just hydrate one area, thicken it, and then you can use a blade or a scissor to kind of get a pocket to do your dissection. Meili's technique involved the use of these kind of dissectors to dissect limbus to limbus, and then you inject viscoelastic in the dissected interface, and then you trephine from the front. The disadvantage of this is that you have a significant amount of stroma being left behind, which may be of irregular depth. If you're, especially if your corneal thickness per se to start with was unequal in different areas. So that's one of the disadvantages, and it's a little blind. So all challenges with the usual manual techniques: sharp instrumentation is needed in the central cornea, higher perforation rate, too much stroma and irregular bed being left behind causing interface scarring, low repeatability and highly dependent on surgeon skill. So you can't be sure that you'll do it the similar way every single time. So we describe this technique of groove and peel technique of manual DALK, in which we make a partial thickness trephination in the cornea, and then you use a regular corneal scissor, universal corneal scissor, to kind of create a pocket underneath your trephination edge like this, and you make an entire circle. Then you make a second round like so. So you basically go around, and then each pass you're going deeper and deeper like a spiral. And at some point, as you keep doing this dissection, you will encounter the Descemet's membrane, or the Duas membrane, sorry. And at this point, you stop dissecting further, and then you start peeling that central island of stroma. Here you have not done any dissection, mind you. It's just the stretch forces that are separating the stroma from the Duas layer. And you can give some counter traction at the limbus or the edge of your trephination if you, as you can see here. So you can hold this and then pull in the opposite direction. Do it gently, don't be very jerky. Sometimes if the force is applied jerkily, it can tear the Descemet's focally. So you want this force to be spread over a large surface area so it will not rupture the Descemet's and the Duas layer. So like this, you can just gently peel off the entire stroma. You may have these little fibrils which practically don't matter either visually or optically. So just show you another video to just reinforce that. So partial thickness trephination. Then in this case a visco bubble was attempted, but it didn't happen. So we initiated the groove and peel technique with a universal scissor. Go around, make a round, and then at some point you will encounter the glassy Duas membrane. Expose about 2 to 3 clock hours of that membrane, and then you grasp the central island of stroma, give counter traction at the trephination edge, and even in the areas where you have not dissected, you will see that the entire thing just peels off very nicely, and you can see the bed is quite smooth, probably as good as what you would get with a big bubble DALK. You don't always get such a smooth bed. You sometimes have a little bit of stroma left behind, but practically it doesn't matter. With remodeling, you'll often get equally good result as a big bubble DALK. And in my hands, I found that this technique is highly repeatable. You can see multiple videos, and I have so many more. You can just do it again and again. So this is my go-to technique when I have to do a DALK, and especially if I just don't want to have a complication. And just to give a representative picture, you can see just the very first day, the stroma is compact and the interface is absolutely clean. You can do it for keratoglobus. There, in fact, you don't even need to dissect because the whole stroma peels off like a LASIK flap. There's really no attachment between the stroma and the predesmetic layer. Even in therapeutics DALKs, we have done it, and because here the cornea is edematous and spongy, it peels off very nicely, as you can see here. So you're able to kind of remove the entire unhealthy stroma. This is a patient in whom we did a predesmetic DALK along with clet. This was a child, so I wanted to be sure I don't have perforation, so we just did a manual layer by layer, this thing using an iris repositor. So any instrument really you can use. You can even use a Sinski hook, and you can see along with the clet a limbal transplant, it gave a very good outcome. It's not that you can't have a perforation with this technique. You can, especially if it's an old hydrops or if you have a deep scar, but if managed well, you can often have good outcomes and just as though nothing ever happened. So now one of these eyes has had a big bubble DALK and one has had a groove and peel. Can you make out which one? I bet you can't. Thank you.
Thank you, Rishi. Always, this is a nice talk, and I am using this technique. I have done so far 12. One perforation happened that I shared with you, but this is a very safe technique. So you have to have all the techniques in your hand to have minimum complication in DALK surgery. Now over to Vanathi. She will be speaking on bubble nuances.
Thank you, Rishi, and thank you, Dr. Basak. So I'll just rush you in the next 7 minutes in the interest of time so that Dr. Fogla can follow suit after me. So much of manual DALK and much of what is important has already been covered by Rishi. So when you look at big bubble DALK, the secret lies in how you would probably achieve your big bubble without converting most of the time. So let's move on in the interest of time uh, to knowing what is the type of bubble you need to achieve. What is the type 1 and what is the type 2? The type 1 is when the Duas layer and the rest of the desmids get separated from the rest of the stroma. The type 2 is the pure desmids bearing big bubble which you would want to get. And this again is from a wonderful publication from Dr. Fogla itself, which is a good diagrammatic representation of how the bubble, when achieved correctly, is going to push your desmids into the anterior chamber. And understanding this anatomy is probably very important also in learning how to achieve a big bubble most of the times, and how you would not want to convert it into a manual DALK or into a penetrating keratoplasty rather. So the tip 1 is a preoperative case selection. Know your corneal thicknesses, know the area where the cornea is thinned out, and you will have to understand or remember to what thickness you need to partially trephine the cornea, which should be a perpendicular cut-in. So this is very important in learning when you insert your needles and in helping to achieve a good bubble, and also in dissecting out the soma when you're doing the divide and conquer removal of the stroma. Most surgeons seem to prefer general, especially when they are beginning, but I think once you're experienced, we are quite comfortable doing our surgeries under regional anesthesia as well. But remember, you do not want to have inadvertent large movements that can cause a rupture of the desmids membrane. Always remember to make your side stab entry before you do your bubble, so your chamber is deflated a little, and you have the space for the bubble to move in and push the desmids into the anterior chamber. So don't keep it too taut, otherwise this could be an impediment to your big bubble achievement as well. And as Rishi rightly pointed out, you should learn to master your manual dissection techniques as well, so that in case you're in trouble, you will be able to convert it into a manual DAC and not into a penetrating keratoplasty. Again, there is a gamut of instruments which have been described, so learn to use these instruments. There's no shortcut to learning. The learning curve of DALK is slightly longer than other, perhaps even endothelial keratoplasty DMEK procedures, but there are a good set of instruments which are available with us which help us to achieve the big bubble. I'll subsequently show you those instruments, quickly run through them after I finish the tips and the pearls. Again, when you're using an injection, air injection, remember when you use a needle, you need to orient it correctly, otherwise the tip of your needle can cause inadvertent damage and perforation, and you would land up with a perforation of the desmids even before you've started injecting. So this is by and large a total coverage of all what you have achieved. And then once the bubble is thin, most times you can perforate doing what is known as the brave slash, so you should know how you're going to go and de-roof your big bubble. Once the de-roofing is done, it is a divide and conquer technique. Again, the right instruments are essential to avoid rupture when you're blunted, when a tip can cause a rupture of your desmids membrane. You can always use the double bubble test or the small bubble test to help you understand whether you're in the right plane, and it's usually helpful when you're doing this in corneas which are not as clear as keratoconus, and you're using them for more opaque corneas as in dystrophy cases. Be careful when you're doing a quadrant removal, because perforations can occur when you're removing the residual anterior stroma, and inadvertent perforations of the periphery can result in a perforation as well. So this is again just a surgical assembly of the things where once you've achieved a big bubble DALK, you see a smooth surface, and in an IOCT you just see what is just left behind is the desmids membrane out over here. And remember, when you're putting the suture, putting your button on and suturing, you would want to wash it up clearly, remove all any viscoelastic or any fibers, debris left behind, because otherwise that is going to affect the results of your good surgery as well. So this is a quick run through of the earlier case itself. It's a 16-year-old keratoconus patient who had a Kmax of over 62, 68, and thinnest Paki of 117. You always remember when in your preoperative case selections, I generally do my DALKs for those cases that I'm not able to fit even the advanced contact lens systems in the patients. So when there's a failure of even scleral contact lenses, or the patient is non-compliant or has a significant ocular surface disease like allergy, then that's when I move these patients onto a DALK. And these patients inherently do have a higher risk of perforation even in the best of the hands. So the challenge and the expertise comes in achieving a big bubble in these kind of cases, in keratoglobus, in pellucid margins, where the ectasia is significantly much larger and more difficult to deal with and achieve a significant flattening and a good unaided visual acuity in this patient. So this is a full video clipping of the earlier points which I pointed out in this particular case. And remember, when you do a big bubble DALK, you get a smooth surface there, and careful trimming out is very important, as if you can perforate if you're not trimming out well. And then you place your donor button on, and the principles of suturing is pretty much same as you would get in any other patients. So you have these DALK instruments which help you to go insert. So you have cannulas and spatulas, and you have which help you to inject air into the stroma and help achieve your big bubble. In the interest of time, I think I will skip running my other videos, and over to you, Dr. Fogla, to take on closing the session with his final talk on conquering DMEK procedures.
Thank you, Vanathi, for making me part of your course. I think Dr. Basak has already spoken extensively about the DMEK surgery. It's not moving. Yeah. So the DMEK surgery, I think the basic technique has been explained, where you prepare your donor Decimet's scroll, and you can stain it, put it into the eye using an injector system, and then you tap the surface, open up the scroll in the right orientation, put an air bubble to keep the donor DM secure in place. So what are the problems that you can have? The donor preparation itself is challenging, and often it has a learning curve. And here you can see that we have been able to successfully peel off, but sometimes when you try to peel off, you can get radial tears, like in this case, where it's got torn because of tight adhesions between the stroma and the Decimets. And this is again another one and you can see these kind of horseshoe tears. So even if you do have some tear in your Decimets, you can still use the donor tissue for your DMEK surgery. So in this case, we had a horseshoe tear, but we were still able to successfully use it for DMEK. And in this case, you can see when we were doing the final peeling, we lost about 20% of the tissue in the periphery, because there was a tear which was not visible because the Decimet scroll was not stained. So nowadays what we do is, after doing a partial peel, we just put a little bit of trypan blue to stain it a little bit. But even if you do lose that little bit of peripheral tissue, it doesn't mean that you have to discard it. So this is like 20% of the tissue was missing, and we were still able to go ahead, use the donor tissue. So we basically told the patient that we use a customized graft for you, a D-shaped graft. So you can have these kind of various tears that can happen, and most of them can still be recovered, except for the last one that you have. If you have such extensive ones, then you may not be able to use the tissue, and still don't waste the tissue. You can use it for a DALK surgery. Loading the tissue, you can either load it from the front by aspirating, or you can lift up the donor tissue and just bring it to your tip of your cartridge, and by capillary action it can go into the tube. Try to see that the open end of the scroll is facing towards you. Now in this case, you can see that we have been able to putting the scroll into the eye. It's a large incision because we did an IOL exchange, and we did place some sutures to bring down the width of the. But if your wound is slightly larger and you have some amount of upthrust because your speculum is really tight, you can have significant amount of pressure, and the more you try to push in your graft, the graft has a tendency to come out with the flow and tries to shoot out of the eye. Now here you see that we are just trying to, we just nudge the graft back into the eye and we complete the surgery. Sometimes if you think that your wound is just 2.8 and you don't really need to suture it, you can see here that you've been tapping and suddenly you will find that your tissue has jumped out of the eye. So always after introducing the donor DM, even if your wound is small, you always place a suture to secure it. This is another one. You can see that we have pushed in the tissue into the eye. The wound is much larger, although we have placed two sutures because of upthrust. So always loosen your speculum, ensure that there is no significant amount of upthrust, and don't be in a hurry to withdraw your tip of the cartridge from the eye. Let the graft settle down in the eye, maybe let it open up a little bit, soften the eye by releasing fluid from the side port, and thereby you can prevent the tissue from jumping out of the eye. If your tissue is oversized as well, so you have to look at the overall corneal diameter and then prepare the donor tissue. Now in this case, the tissue we prepared was about, we wanted to add in more endothelial cells, so we prepared something like a 9 millimeter graft, and you can see that we are having a tough time trying to get the entire scroll into the eye. And then you have to, touch the graft a little bit just to push it into the eye. Orientation wise, we know that the open end of the scroll, if it is facing towards you, that's the right orientation. Now in this case, sometimes when you're looking at vertical head on, you can get confused. In this case, we thought it was the right orientation. We opened it up and we put an air bubble, and we thought that we did very well, and post-operatively, this is how the patient looked. You can see that the scroll is scrolling towards the iris, which means that we put it upside down, and this patient we had to go back and we had to repeat the graft. So that's the same patient. You can see that we are removing the previous DM scroll, and we prepared a fresh one, and we put it into the eye. This time we ensured that the orientation is the right way. And before I used to mark this, there was always a tendency that if the cornea is very edematous, to identify the right side of the scroll can be a bit challenging. But after, so that's the same patient after redoing the surgery, you can see they did very well. So this is the putting the S stamp or the F stamp through a stromal window was a technique conceived by Philip Dye from the Lions Eye Bank in Portland. So you peel the decimates, you do a stromal punch, 3 millimeter or 2 millimeter, and then you go back, and from the stromal side you can mark the decimates, so that helps you identify. So you have a S stamp. The other thing is, if you have a very deep chamber, also sometimes it can be a problem. Also the air bubble that you, so in this case what happened, we just watched the video again, we had opened up the graft beautifully, and using a 5cc syringe, I am injecting air, and I injected too much of air at one time, so the air bubble pushed my graft to the angle. So I had to go back, remove all the air bubble. I had to go and work on my graft to open it up again. And the more you work, the longer time you spend, the trypan blue stain also tends to fade away, and sometimes visualization becomes a problem. So when you're supposed to put an air bubble, now what I do is I use a 1 ml syringe with only about 0.1 cc of air, so that even if I inject more, I only get a small air bubble. I don't get a large air bubble that can push my donor graft to the opposite end. So here you can see that the orientation, and I realized that it was the reverse orientation, so you can just inject fluid from the side port to flip it over, and then you can get the right orientation. So this, having the mark really saves time. You don't have to really deepen the chamber to look at the natural orientation of the scroll. You can just, the moment you see, now you can see the F mark is looking in the right orientation, you can go ahead and put your air bubble. So you can sleep more peacefully when you have a mark and you know that you have put in your graft the right way. Otherwise, a lot of time, you're always in doubt, did I do it right? Is it not the other way around? And and that's more so when you have an edematous cornea. So in this case, it's a post-graft eye. We have put in our graft into the eye. So usually we keep the eye slightly hypotonous. We keep the chamber slightly shallow. And if you have a bleed from your wound, there is a tendency for the blood to seep into the eye. And if you get blood into the eye, and if it mixes, then sometimes you can get a fibrin response kind of in the anterior chamber, and your decimate scroll can either get stuck to the iris or the folds can get stuck within themselves. So here you can see that we managed to open it up. I was not really worried about centration. I was more worried about the blood that's seeping into the eye. So I went ahead and I put my air bubble, and fortunately for me, the orientation was the right orientation, and this was the end of surgery. If you have this kind of a cornea where the cornea is really hazy, it's a failed graft, you can put put in your graft, and to improve the visualization, you can switch off the microscope lights, and you can then use a light pipe, and with that you can look at the orientation of the scroll, and sometimes you can use that to even complete your unfolding of the donor tissue. If you have a very tight scroll which is difficult to open, you can use one of these cannulas which is closed at the tip. It has 2 side ports, so you can put it inside the scroll and you can give one burst of fluid, and that opens up your scroll, and that helps in the unfolding process. You can have DM detachment that can occur in the post-operative period. You can see like this, it looks. So the DM detachment, if you have a partial DM detachment where part of the graft is attached and only part is detached, you can just observe over a period of time, and usually the detachment would suffice. But if you have a total detachment, often they will require rebubbling. And that's why we need, even the stripping process, if you have stripped smaller than the size of the graft, you can see that the area where the host DM is still present, the chance of the donor detaching is a little higher. So now what we do is, when we are stripping the decimates, we try to overstrip. That means we go 8.5 or 9 for an 8 millimeter graft. Now in this case, we did not intervene, and over a period of time, you can see without intervention, the cornea cleared up. However, in this case, where we had used a younger donor, and this was a patient with a tube implant, and the donor I had was a 28-year-old donor. I managed to finish my surgery. My patient went back. He came back to me a month later with this kind of a picture with detached, and you can see the scrolling of the decimal shows that it's in the right orientation. We were able to go back. It was a younger donor, so I assume that it has a higher viability of endothelial cells. We manipulated and opened up the DM, and you can see that the cornea cleared up pretty well. So this is, again, we spoke about, it depends on the size of the removal of the host decimus membrane. Using 20% SF6 seems to have a lesser chance of rebubbling. It reduces the rate of rebubbling compared to air, so that is something you can use when you're starting with your DMEK surgery. So I think we're exactly on time. It's 1:25, and DMEK steps are slightly different from DSAEK. So just you don't apply the same principles of DSAEK to DMEK. Each surgical step is equally important, whether it is wound from decimus preparation or the wound construction, and recognition and early management of complications can smoothen your learning curve, and it's a relatively easy technique to learn. Thank you.
Thank you very much, Dr. Fogla. And I think with this, we'll conclude this session, and I thank you all for being with us in this pre-lunch session. Thank you.